Uh, cool. So welcome everybody to our second edition of A Closer Look Biomechanics Journal Club. And today we have the honor of hearing from Dr. Lucas Timmins, who's a assistant professor in the Department of Biomedical Engineering at the University of Utah. He got his PhD from Texas A&M under Professor James Moore, and then was a postdoctoral fellow at Georgia Tech under Professors Giddens, Oshinsky, and Samari before joining the University of Utah, where he has been, I guess, for the past 4 or 5 years. I think so. And his lab, we can probably put the link. I actually had copied the link to his website if you want to check out more of his work. I'll paste that on the chat a little bit later. But his lab focuses on cardiovascular biomechanics, so both how mechanical cues affect the pathology and physiology of cardiovascular systems. And today he's going to be talking about one of his recent papers on establishing automated algorithm using OCT and micro-CT imaging to reconstruct the 3D deformed stent geometry. And yeah, so I'll post the link to the website on the description, and then I'll let Professor Timmins take it away.
All right. Well, thanks, Adrian, for the really kind introduction. And thanks to you, Emma, Manuel, and Johannes for arranging this really excellent seminar series. And I very much enjoyed Professor Kurt's talk last week or 2 weeks ago. And interestingly, both of our publications were in the same journal. And it's actually not considered a biomechanics journal, but I hope students just realize just the broad application of biomechanics in the medical field, particularly in medical imaging. So as Adrian mentioned, I'm going to present some of our work in the setting of vascular stenting, and specifically kind of a method we've looked at developing that allows us to reconstruct the geometry of a stent deployed in vivo in 3D. And I do want to highlight, because Emma brought this up, you see a nice photo. This is the Salt Lake Valley. In the spring, summertime, the university sits about right there. And my background is what the mountains look currently, just wonderful, about 100 inches of base snow up in the ski resort. So we get to enjoy that with all the free time we have. This is a multidisciplinary collaboration I do want to highlight, led by Mark Elliott, who was the first student in my lab, a master's student, who really was key in kind of driving this project. It was in collaboration with colleagues in the Ski Institute here at Utah, the Scientific Computing and Imaging Institute, collaborators in cardiology at Emory University, and also a collaborator in Ireland at GMIT. So just to give everyone kind of a primer, a larger background of the work that we do in this space, a lot of our research is in the setting of vascular stenting. And vascular stenting is the primary treatment for coronary artery disease. So coronary artery disease, I'm not going to put up all the statistics. It's the #1 killer across the world. It accounts for about 50% of all cardiovascular disease death, but it results in a reduction in blood flow in the vessels that feed the heart, and essentially can lead to clinical events such as heart attacks that require intervention. So vascular stenting, this is actually one of the most common medical procedures in the US healthcare system. It happens about 600,000 times annually. And it involves essentially the placement of a scaffold that props open a diseased vessel. So what you're seeing here, this is a coronary angiogram. This is performed when contrast is injected directly into the vessels that feed the heart. So in this case, we're looking at the left side of the heart. And what a clinician looks for when they inject contrast is kind of irregularities in the anatomy, reductions in blood flow of this contrast agent, and they use it to determine whether or not they're going to intervene. So a little bit hard to see here, but there is a little bit of a restriction right there in that first diagonal vessel. This is a main vessel that feeds the left ventricle. So instances where a clinician sees a reduction in blood flow, they would go in and deploy what we refer to as a vascular stent. So this little kind of 1, 2, 3 step system describes that process. A catheter is wired up to the intervening region. A balloon is deployed essentially to expand that stent. That balloon is deflated, the catheter retracted to leave that metallic structure in place. And you see I have a nice little image there of balloon inflation just on a simple bench top. Now, after that balloon is deflated and removed, a follow-up angiogram is performed. And if you compare where that stented region and where that lesion is, you see a really nice patent blood vessel. Potentially the patient sees immediate reduction in pain, particularly potentially shortness in breath. But again, it restores blood flow to the diseased tissue to prevent changes in heart failure, etc. Now, stents have been around for about 40 years now, and they're continually advancing. This is advancements in the technology, advancements in the treatment guidelines. These are continually being updated. And ultimately, these have collectively reduced complications associated with vascular stenting. So for example, in the technology side, drug-eluting stents, which we'll get to in a second, these were a big advancement in treating the failure of these devices. Anticoagulation, antiplatelet therapies to reduce thrombus formation on these devices, et cetera. Again, these have really reduced those periprocedural complications. Now, coming from a mechanics background, the deployment of a stent, I consider is really a mechanical solution to a clinical problem. And I say that because we talk about the inflation of a stent. These balloon inflation pressures are incredibly high, thousands of millimeters of mercury. You have an incredibly non-homogeneous deformation of both the stent and the vessel that's shown by that balloon inflation video there. And of course, you have permanent deformation of this stiff device to leave it in place. Now, when we talk about the response to stenting, it's not too dissimilar from a foreign body response when any biomedical device is implanted, but there are some unique aspects related to the underlying vascular biology. And so there's kind of been described as really 4 phases of vascular stenting. Thrombosis is the first one. This is the deposition of platelets, blood cells on the stent surface. So just to give you an idea, some histopathology training here. This is kind of a zoomed in cross-section of a vascular stent, this kind of void region where that star is, that's where actually the stent strut is located. And these red cells, these are red blood cells, both on the surface of that disrupted endothelium, as well as near that stent strut. You also have significant inflammation, presence of eosinophils, blood cells involved in the inflammatory cascade. And ultimately, you get significant proliferation and remodeling of that vessel. So this final image here on the right, what you see, these little void regions, those are actually the stent struts themselves. This is a cross-sectional image. But you see a significant amount of tissue ingrowth, right? And this is primarily smooth muscle cells, fibroblasts, laying down ground matrix that truly remodels the anatomy and underlying lumen shape of these stented regions. Now, unfortunately, these devices can fail. They fail from two primary mechanisms. The first being neointimal hyperplasia. That's the ingrowth of tissue into this region that essentially restricts blood flow again, so it forms something, a new stenosis, essentially. But you could also have stent thrombosis, and that's the formation of a large blood clot that again can—
Hey, Luke, sorry for interrupting you.
Yeah.
Can you move your slides back and forth real quick?
I
think I and some others have lost your feed.
Okay. Let me try this again. Sorry about that. Let's try this. Can you see it now?
Yes, I do anyways.
Yes.
So you can see advancing slides?
Yes.
Yes.
Okay. I apologize for that. I'll leave this up for a second, just to show the some of the videos here. Particularly that kind of balloon inflation of the stent on the bench top. So moving on, just continue with the pathobiologic response. The 2 failure mechanisms, neointimal hyperplasia, stent thrombosis, these can lead essentially to the formation of a new blockage we refer to as restenosis. So this is an angiographic image here. You can see the stented region I've kind of highlighted, and you can see kind of low, very low contrast in this region, and that's indicative of a new blockage. In this case, the clinician would go in, potentially deploy a new stent, or more commonly actually send this patient to the surgical room for bypass surgery. I mentioned drug-eluting stents, have really advanced this field. Unfortunately, they have not been without their problems. In fact, some pathology data, Renu Vermani being a key player in that space, has really demonstrated that with drug-eluting stents, while they minimize the amount of neointimal hyperplasia, they elute a drug that essentially minimizes cell proliferation. The lack of the cellular response can result in something referred to as late stent thrombosis. So a blood clot actually forms on these stented regions, again, leading to failure. And here's a cross section showing a stented region that's been completely occluded by a thrombotic event. Now, if we look at current failure rates, again, 600,000 stents deployed annually. Failure rates vary quite significantly between 3 and 20%. So it's not an insignificant number. And these failure rates depend on patient characteristics, lesion complexity, and also the stent platform. So as with all areas of medicine, biomechanics plays a key role in vascular stent response, as well as the failure of these devices. And really the altered mechanical environment following deployment of a stent is a driver of both neointimal hyperplasia and stent thrombosis. So in the setting of solid mechanics, non-physiologic stresses, high stress fields have been shown to promote neointimal hyperplasia. This study specifically looked at 2 stent designs, custom stent designs, known to induce variations in the circumferential stress or mechanical environment. These stents were actually deployed in an animal model and was shown after about a month in these animals that a stent that induces higher stresses actually results in increased neointimal hyperplasia or tissue response. In addition, deploying these devices, they do interrupt the flow regime, although at a very focal level. But these disruptions in that flow field increase platelet deposition, increases thrombus deposition, as well as neointimal hyperplasia. So this is just a nice kind of experimental and computational image here on the right side. You're looking at shear stress. You see near the strut, you have regions of very low shear stress. And in this case, they were looking at radio-labeled platelets, and you see an increase in platelet deposition in those regions where you have those kind of disrupted flow fields. So, this was work that's been around for about the last 10 to 15 years. And a question, I always ask is how much of this has actually been implemented in the clinic? And unfortunately, we know a lot about biomechanics and its role in vascular stenting and the potential failure of these devices, but really not a lot has been pushed into the clinic. And really a major focus of my lab is to, take what we do in the laboratory and really apply it in the clinical setting, to use it to guide patient management and how clinicians make decisions on treating their patients. So in the setting of vascular stenting, kind of a first hurdle in this space is we still can't visualize a stent in 3D in vivo, right? X-ray angiography doesn't have the resolution, neither does CT, and all the intravascular imaging techniques only acquire cross-sectional or 2D information. So to kind of overcome this limitation of this work, we sought to really develop a technique that allowed us to reconstruct or visualize that stent in 3D in vivo. And the idea is if you could do that, you could then think about performing these simulations to evaluate the mechanical environment, whether looking at the solid or fluid mechanics. So the efforts that Mark led in this space looked at really combining multimodal imaging data with previous knowledge of stent design to reconstruct the stent at a high resolution in 3D. And if you remember any image from this presentation, this is kind of the overall schematic of the work. So this was initially performed at the experimental level on the bench top, and we actually deployed stents in arterial phantoms. Optical coherence tomography imaging data, or OCT imaging data, was collected. These imaging data were segmented that allowed us to essentially create a 3D point cloud shown in blue here of the OCT defined stent struts. In addition, an identical stent was deployed on the bench top in open air, and actually micro CT data were collected. This data were parameterized to create a wireframe, and we used something referred to as diffeomorphic mapping, which I'll get into, that allowed us to deform that wireframe to match that in vivo OCT point cloud to give us a full 3D reconstructed stent design. So in terms of our experimental platform, there's some benefits to that, which I'll touch on at the very end. We evaluated 2 commercial stent designs, one made by Abbott, one made by Medtronic, the Xience and the Resolute platforms. And there was kind of 2 reasons for this. One is these are really some of the primary commercially available stents implanted, readily in the cath lab, but also they have very unique designs, right? The Xience Alpine has this really unique kind of axial connector. It's considered a closed cell stent design, whereas this Resolute Integrity, this is a stent that's made out of a single wire that's actually coiled in this configuration. You kind of have these weld points, but it's considered an open cell stent design. Now, we deployed these stents in, like, as I mentioned, arterial phantoms that our colleague in Ireland made. These were both healthy as well as diseased or stenotic phantoms. And then we acquired, again, 2 modes of imaging, OCT being the clinical imaging modality that's used in cath labs across the world. And we did this, you can see OCT, this is a light-based imaging technique. That light actually rotates thousands of RPMs around that catheter as it's pulled back to that stented region. So this is the stented region about right where my cursor is. And this is what that pullback looks like, and you have cross-sectional images of that pullback. I want to highlight this is a light-based technique. Stents are made out of metal, so you get significant artifact or actually just shadowing behind the stents because light cannot penetrate through the structure. So it's by eye pretty easy to identify where those stent struts are in an OCT pullback. In terms of imaging resolution, OCT is incredibly high resolution in plane, about 14 microns, but you do lose some data in that imaging, that spacing between images. So images are acquired about every 100 microns, right? In contrast, micro CT, again, these were deployed in open air, isotropic voxel resolution of 15 microns, so incredibly high resolution. And we also acquired micro CT data of those stents that were deployed in the phantoms, and it will make sense why we did that shortly. So the first step in this process was to detect these stent struts in this OCT images. This was developed through various, image processing algorithms, some pre-processing that allowed us to window the data. So we applied, for example, things like a Huff transform to identify circular objects in these images. We could identify, for example, the catheter, what we refer to as the perivascular boundary, and that kind of just windowed or minimized the amount of data that we were looking through. In these images, because this is acquired essentially around the radius, so at every circumferential position, we classified these A lines to determine whether or not they were a stent strut or they were the lumen itself. And they have various different intensity signatures, those struts having incredibly high intensity and then a significant drop off due to the shadowing. And once we identified the stent struts, the continuous struts, A lines were kind of combined, and we could identify a strut centroid by just taking the half width of the strut thickness. So what this allowed us to do is create this OCT-based point cloud. And just to determine how kind of well our algorithm was at detecting these stent struts, we did validate them against an expert reviewer. We had 2 stents, again, deployed in a healthy versus a stenotic phantom. And this is kind of some of the image or the data that we evaluated. So for example, this Zion stent in the stenotic phantom, about 184 images had stent struts. We identified nearly 2,000 struts. Sensitivity was about 72%, whereas positive predictive value was 97%. So for those that aren't familiar with that, so sensitivity, it told us we did not detect every stent strut. So we only detected about 70% of the stent struts. But of those stent struts we detected, positive predictive value says 97% of them were actually stent struts. So we were really good at identifying exactly a stent strut, but again, not every strut. And if we look at intra versus intra-observer analysis, that positive predictive value of our algorithm was on par with manual expert reviewers. So the next step, once we've identified that OCT point cloud, was to take our micro CT data and generate what we refer to as a stent wireframe. And we actually utilized a technique that was looking at the morphology of cortical bone, looking at applying, taking our volume of that micro CT, performing thinning to reduce it down to kind of a single voxel wireframe, and then converting it to graph representation. And in doing so, we did end up with these kind of spurious nodes, and we essentially modified this graph representation to only contain critical points. So what I mean by that, on the right here, you see we've identified essentially nodes and links. The links representing kind of the long axes of these stent struts, whereas the nodes are areas like, think of it as hinge points where that stent can deform based on the deformation of those links. So this kind of gets into the meat of the work that we did in terms of identifying a way to essentially map that wireframe to that OCT defined point cloud. So on the left here, This is kind of a pipeline we refer to as constrained iterative deformation process. So the first step is we had to spatially co-register these data, right? We had an OCT point cloud of the stent and the phantom, and then we had that wireframe. So using just method of moments and cross correlation, we could essentially get these two kind of domains in the same spatial region, right? Not the exact same location, but in kind of the same ballpark, if you want to say. And then we really relied on a lot of work that our colleagues in image processing have developed that's been applied and significantly in biomechanics. This is something referred to as deformable image registration. So for any photographers out there, whether professional or amateur, image registration is something that's really ubiquitous across what we do, right? In terms of photography, taking multiple images, we're increasing that SNR. But the idea is transforming different data sets so that they are aligning kind of one coordinate system, right? In the case of deformable image registration, you basically allow kind of a deformation or elastic transformation to map a source image to a target image. So the idea is you're trying to understand what that transformation is that allows one to map a source to a target. And to tell you that you can turn a circle into a square, this is a nice example of that, where on the left you see that circle deforming into that square, and on the right side you actually see that displacement field. So as you can imagine, kind of pulling the circle at those corner regions of the square, you have the highest displacement, again, being able to map that source to a target. For those of you that are FEBio users, you may remember this. This is actually a plugin referred to as hyperelastic warping. This is the kind of example module they use. We didn't use this in the process. We utilized something referred to as diffeomorphism, where it actually originated in kind of developing the brain atlas, the idea of identifying different regions of the brain by using this image registration or deformable image registration. So in our case, we used something referred to as diffeomorphism for our deformation process, and also referred to as diffeomorphic metric mapping, or DMM. You may see that throughout the presentation. But the idea with DMM is it seeks to identify the transformation that really minimizes the difference between 2 point clouds. And I've always been said you can only have one equation in a presentation. This is my one equation here. But essentially what this equation tells us is we have this, we're looking at identifying this optimization function of this transformation phi that's a sum of two parts, a regularization term and a dissimilarity term. The dissimilarity term, that's basically the distance between the 2 point clouds. And in our case, the point clouds are that open air wireframe and that OCT point cloud. And then you have that regularizing term, which is basically just the function of the distance between the identity transformation, in this case E, and ultimately your transformation phi. And you'll see in the next slide a nice representation of really what this equation means. But this process can be thought of, our stent was a viscous fluid, and we allowed it to kind of flow or deform to match that OCT point cloud. And this parameter gamma here actually controlled that viscosity. I'm not going to go into a lot of the details, but these diffeomorphic mapping processes have several terms embedded in the dissimilarity and regularizing term. And we use really Monte Carlo analysis to perform a multimodal parameter sweep across these terms and really tune it for our problem of interest. Now, an important component of our deformation process is we refer to as form constraint. And the idea is we had to actually constrain these point displacements to make sure that the resulting deformation was actually physically accurate, right? The idea is that we did not have a physically ill-conceived stent geometry. What I mean by that, this is an example here. Black here is essentially an initial wireframe, and gold is that first iteration of that DMM. Without constraining it, you can actually get significant deformations that are really unrealistic. For example, you can see these stent links actually stretch quite a bit. Now, these are primarily made out of stainless steel, and we know they're not going to deform in that way, right? And so what we did is we actually constrained the length of these stents. We constrained kind of the nodal angular orientation to make sure that our deformation was actually representative of the underlying stent design. And we really iterated through this process until we identified kind of a minimum Euclidean distance, a convergent state that we had actually mapped or warped our wireframe to that point cloud. And this is just a nice image here that tells you what that process is. So OCT point cloud, the blue open circles, that wireframe in black there, and you can see the wireframe kind of jiggling and moving around until it really nicely matches up with that OCT point cloud. This is both kind of opened up where you're looking at Z versus theta, and this allows you to understand kind of the expansion in the radial direction of that open air stent to match that wireframe. So in terms of that constrained DMM across iterations, this is just looking at a couple examples, but they did rapidly converge around 5 to 10 iterations on the order of about 10 minutes through this entire process. And this is an example of the movement or the deformation of that wireframe to match that point cloud. And the color here is indicative of displacement from the previous iteration. So if we kind of focus in a region in the top right, you can see there's really not a lot of agreement between the wireframe and those open circles, the OCT point cloud. But through those iterations, you have significant deformation or displacement through iteration 1. Once you get to iteration 4, you really see nice agreement between the data. Of course, when we're talking about convergence, a majority of that distance minimization occurred in that first iteration. But by about the 4th iteration, we had reached a converged state. And if we actually break it down to the components of that displacement, the principal axes being the axial and radial displacement, the secondary axes being kind of circumferential displacement, we really see that first iteration, you had significant expansion in the radial direction, and then kind of fine tuning in that axial and circumferential directions. So I mentioned we acquired micro CT data of that stent deployed in the Phantom, and that really allowed us to have a ground truth information, right, to determine or really validate our diffeomorphic metric mapping process. So what we had is our wireframe in open air. It deformed through that diffeomorphic mapping process, and we could then compare it to a similar wireframe of that stent deployed in the Phantom.
Right? Hey, Luke, there was a question in the chat real quick for you.
Sorry about that. Let me.
Oh, don't worry. There's lots of text there. That's why I'm mentioning it.
Yeah, I could also say it. I didn't want to be the first to interrupt. Is there? Hey, Luke, is there any concern about overfitting when you do your convergence? Like, do you have to worry about the displacements matching, like the grid spacing being a little different?
Yeah, so overfitting, I guess in terms of going back to the original equation, kind of the regularizing term helps some of the overfitting. In terms of overfitting based on the number of physical data points, which I think is your question asking.
Yeah, exactly.
That OCT point cloud is not as dense as we would like sometimes. And I think because of that, it actually helps, right? So it really minimized the potential for overfitting. And actually, if we have a denser point cloud, we actually never saw overfitting. So it really never was a concern of ours.
Okay. Yeah. Awesome. Thanks.
Yeah. Sorry, Manuel. I thought you were monitoring the chat.
Oh yeah, I am monitoring the chat.
Oh, you're okay. Okay.
Sorry. I didn't mean to say you should have seen it. I just wanted to encourage John, to interrupt.
Gotcha. And feel free others to chime in if you have any questions.
And to be clear, I am monitoring the chat, so you don't have to look, Luke. Yeah.
All right, thanks. Yeah, so getting back to the validation, we had kind of these two wireframes. We could have just done a closest point, but in reality, that really wasn't the appropriate metric, just to look at the Euclidean distance between points on these wireframes. So we actually looked at corresponding points. And what I mean by that is we were able to identify the exact same points in the Phantom wireframe versus the deformed wireframe. And we evaluated the distance between those points, right? And that made sure that we were comparing essentially kind of apples to apples here in terms of the ability to validate our mapping. And if we look at the total Euclidean distance across these 4 Phantom vessels, we have a mean across these 4 of about 180 microns. And if we think at the strut thickness, stents have a strut thickness of around 100 microns. So we're within about two strut thicknesses away in terms of that ground truth validation. If we look at kind of histograms, we definitely see kind of a leftward skewing of these data. 25% of the data is within a strut thicknesses away. And again, a mean of about 180 or 200 microns. So we're really happy in terms of the ability of the DMM to create basically a morphed stent geometry which matched that in vivo configuration. So John, this maybe might address your question about overfitting. So you may recall that our algorithm in detecting stent struts did not identify every stent strut. In fact, some would say our sensitivity was rather low, 70%, one was all the way down at 40%. But of those stents that we were detected, nearly 95, 96% of them were in fact stent struts. So to determine the sensitivity of the DMM to that OCT point cloud, we actually ran the DMM against the manually detected stent struts. And what we saw is really minimal difference between the manual detection and that automatic detection. So there was no significant difference there. You see the means are fairly close together. So we were pretty happy that there was no potential for overfitting, or you could say even underfitting, because we had too sparse of a point cloud. And this really says that our goal in this whole project was not to develop an algorithm to detect stent struts from OCT image data. I'll leave that to the image processing experts, but we could actually, our process worked fine given the algorithm that we had in fact developed. So of course, I want to get into just a little bit of the extension of the algorithm, just one quick slide, because this was all done experimentally. Hopefully you saw the benefit of that is we had control over everything, right? If we were to go ahead and straight move this in vivo, there's no way that we can deploy this in a patient and then harvest a coronary for any micro CT data, right? So this allowed us to have ground truth information that we could really tune and evaluate our different diffeometric mapping process. So for those of you that may be familiar with some of the work we do a lot of work at the patient-specific modeling level, both in the fluid and solid domain, and we look at developing these kind of patient-specific modeling pipelines. I have some great collaborations with colleagues at Emory involved in numerous clinical trials. So we're looking at integrating this developed framework into the clinic so that we can actually deploy or visualize these stents in 3D, right? And so in terms of our pipeline, we're collecting OCT data in vivo. We did have to alter our segmentation a little bit because now we're dealing with tissue, which has different optical properties as opposed to silicone, to identify our OCT point cloud. And then we had to integrate the curvature of the data, right? Biplane angiography to evaluate stents, the center line of these OCT image data. And ultimately we can get a kind of a curved geometry of that stent in vivo, right? And I can tell you that, moving to in vivo is not always the easiest. And we actually saw a couple of things that we didn't anticipate, right? And so what you see here on the left, this is the micro CT wireframe. You see just a very straight, well-organized stent. But in terms of the OCT point cloud, I do want to point out this little shadow here. That's actually an artifact from the guide wire. But the stent actually, it's not aligned, if you want to say, along kind of an axial direction. And a way to really visualize that is here I've drawn a line connecting these axial connectors for the micro CT wireframe. It's straight. But with that point cloud, you see that there's this kind of drift, right? And again, we didn't anticipate that. But what we've since determined is actually curvature plays a big role in the orientation of that drift, right? And so my students enjoy going up to the cath lab. This is Mark, he's doing some experiments up in the cath lab at the School of Medicine here at Utah. He's wearing this nice teal lead vest due to the radiation because of the X-ray. And we developed this little channel that allowed us to acquire OCT data at variations in curvature. And we processed the data and did show that the amount of curvature did drive the amount of drift in the kind of the, I refer to drift as kind of the drift of that center line here. Curvature was a driver of that. So we could identify a correction factor, integrate that into our algorithm to remove this kind of artifact that we did not anticipate going in vivo. Right. So, we're still working on that kind of extension of this work, particularly on the in vivo application. So in terms of kind of the overall discussion of the work, the goal of the technique initially at the experimental level was to really validate a computational framework to reconstruct a geometry in 3D. And I have there in parentheses non-biased, because there was absolutely zero human involvement in this algorithm. What I mean by that is we import the micro CT data, we import the OCT image data, and the kind of human element is removed. And that's kind of, there's novelty in this work because there are a couple other groups trying to develop these processes, but there's a lot of manual implementation. And we really seek to really remove that and create these non-biased frameworks. The idea is with this reconstruction technique, of course, we can visualize the stent in 3D. That allows some volumetric assessment, purely volumetric assessment from the clinical imaging data. And we're looking at using this to guide post-stent geometry and guide post-interventional strategies. What I mean by that is there are instances where the stent is under-deployed, and it's kind of, has parts of the stented region that are kind of, in contact with the blood in all directions. It's not, directly opposed to the vascular wall. And this allows us to really evaluate that at incredibly high detail and quantify that. So we're looking at using this technique from a pure visualization aspect to guide interventional strategies. But of course, our big interest is evaluating the in vivo biomechanical environment. And so we have significant ongoing efforts to integrate this framework into some prospective clinical trials we're involved in to evaluate the role of hemodynamics in device failure. And so what you're seeing here on the right side, this is actually a patient-specific reconstruction of a stent in vivo looking at the shear stress. So we have patient-specific velocity data that we apply to these computational models to evaluate the fluid mechanical environment. There's probably a year worth of methods that I'm not going into in here. The meshing of these geometries was incredibly tedious, just in terms of the size of the vessels that we're dealing with, in terms of just the really kind of unique geometric features of these devices. So, we're looking at kind of streamlining that process, but ultimately with these data, we're actually comparing them to longitudinal data. Longitudinal is these patients' imaging data are collected over time. So we can actually relate the biomechanics at baseline to ultimately the success or failure of these interventional devices. So with that, of course, there's a great deal of work that others should be acknowledged. Again, Mark Elliott, key driver of this work, where my cursor is, just leading this diffeomorphic metric mapping process. Excellent work by David, Michael Kaiser, Dan Kim, and kind of taking this after Mark departed the lab. And of course, our collaborators, both in bioengineering as well as cardiology here at the U, collaborators elsewhere, and of course, our funding sources. And, this is some nice images of the lab. This is pre-COVID, where we could go out and enjoy the nice Utah outdoors. This is an image from our lab Christmas party where we're having a little lab Jeopardy on Zoom. So with that, I want to thank you guys. I'd be happy to answer any questions about this work. So thanks very much for your attention.
That was amazing. Big round of applause for our speaker. And straight on to some questions. Do you want me to read them to you? Thanks again. Look for the talk, and then we have already one question about how robust are the stent form constraints.
Yeah. So thanks, Pierre, for the question. So the question, if you're not looking at, is how robust are the stent form constraints, and do you think you would need to implement new constraints for each stent design you would like to test kind of in the clinic? So in terms of the two stent designs we've looked at, the form constraints have really satisfied that we don't get these ill-conceived stent geometries. And I didn't show all the examples, but the DMM process can result in kind of this tangled mess of a stent if you don't really constrain its form. So we're very happy with where it stands right now. That being said, with some other designs we're looking at that has other unique features, those form constraints are something we'll definitely have to adapt, because each stent design does have these kind of unique little structural properties, probably really centered around the IP or intellectual property of these devices, that we really need to focus on to apply this more broadly.
We have another question.
Karine here, what are some important considerations to take into account when taking the study human trials, adjusting for hemodynamics? So Karine, that's I could probably talk 30 minutes about that. I think when you talk about important considerations, I really have to applaud the collaborators we have in this space. So when I talk about patient-specific modeling in this setting, all of these data that we integrate into these models are in fact patient-specific, whether it's blood velocities, blood pressures, underlying geometries. I really can't thank enough our colleagues in the cath labs that spend sometimes multiple hours collecting these data on patients, but also the patients that volunteer to be involved in these studies. I did mention they were longitudinal, so these patients do come back over time. So in our aspect, important considerations, it's trying to really move our modeling from generalized computational models to that patient specific level so that we can then evaluate any pre-interventional planning or post-interventional strategies at the patient specific level, because the response is definitely dependent at the patient level as opposed to kind of at the stent level. So that's, our considerations are really centered around quantifying and evaluating these data in an individual patient.
Right, we have tons of questions. By the way, if you want to ask your question, also feel free to unmute yourself, Mudran, if you want to speak out, or otherwise I can read it.
Yeah, sure. Thanks, Adrian. Great talk, Dr. Timmins. I was wondering, how sensitive is your pipeline to imaging data quality and sparsity? And do you think this could be adapted to, say, intravascular ultrasound images?
Yeah, thanks, Berdang. I really appreciate the question. So in terms of image quality and sparsity, so image quality is important, absolutely, whether it's being evaluated experimentally or in the clinic. Experimentally, we were able to, of course, cath these vessels and image them for hours and hours and hours with no issues. So we weren't necessarily concerned about quality. You know, we made sure that we could visualize the stents. And I can say at the clinical level, our colleagues understand the data that we're looking to analyze and do make sure the data is of highest quality as possible. So I'm not as worried about the image data quality. And in terms of sensitivity, because we really kind of gate check these data, we've yet to had to exclude any of our subjects that we've looked at. Yeah. So in terms of adapting this to IVUS imaging or intravascular ultrasound, so unfortunately, IVUS really doesn't have a great resolution to identify stent struts. You know, it kind of can, but it can't really well. So in terms of resolution, IVUS imaging is about 150 microns. And the resolution of these stents, the dimensions on the order of about 100 microns. So IVUS really cannot be is not a huge benefit here in visualizing that stent geometry, which is why we really focus on OCT. There are definitely some benefits to IVUS from other aspects of research that we do, particularly for the penetration of the ultrasound into the vessel wall to get information on plaque components. But in terms of evaluating stent geometry, OCT is kind of really the only current modality that we can utilize.
Thank you. Thank you.
Good. We have another question from Adam. If you want to ask your question, feel free to mute yourself, otherwise I can read it.
Sure. Hey, Dr. Timmins.
Hey, Adam.
So this technology seems like kind of next generation catheter to me. Do you think that this approach could one day be used in real time to guide the placement of stents, or maybe more in the near term preoperatively to plan or help guide the planning?
Yeah, so fantastic question. That's definitely our long-term goal, is basically use these strategies to aid the kind of procedural planning of these interventions. Real time, you know, I'm not sure we're there yet, and I'm really, you know, I'm not sure it's something I want to say we want to shoot for. And I say that because the cath labs, there's a lot of stuff going on, right? And there's a lot of, you know, monitoring various aspects of the patient, and you know, a lot of these patients that are stented are coming in because they actively have a heart attack, and because of that, the procedures are very, very rapid. So I'm not sure that this is something that we're looking at real time yet. It's more about the kind of the preoperative planning, as you say. So the idea is patients would be able to go in, get cath, for example, acquire these imaging data. We do our kind of work and then kind of guide the appropriate intervention. And that's not really too uncommon. Patients do fail stress tests in the cath lab. When I say stress test, this is not mechanical stress, but stress on the heart to look at reduction in blood flow. So because of that, you know, patients commonly go in the cath lab, get these imaging data collected, and then come back later for procedures. So that's where I see kind of our work, you know, being integrated into.
All right. Any other questions from?
I have a question.
Yes, go for it. Yes.
Hey, Luke, great talk. I have actually two short questions. So number one, with OCT, one of the issues, I mean, I also use partially OCT in my research. One of the key obstacles that I see is the speckle noise that we measure for the type of measurements that we do. So you mentioned the shadowing, which was obviously like a kind of a challenge in your case. How about speckle noise? Because you use point cloud, I'm assuming that that was a challenge too. And how do you tackle that? And number two is for percutaneous corner intervention. So I'm assuming that if you have like multiple blockages, probably doctors use multiple stents, I'm assuming. In that case, like would your strategy be still applicable, or would you need to change something? Would be my questions.
Yeah. So two great questions. So when you say speckling, are you referring to kind of the blood artifact that you commonly see with OCT data?
Exactly.
Yeah. So that's not something I went into. A benefit of experiments is we were only working with saline. And so light can pass through saline without much artifact. I should say in vivo, blood introduces tremendous artifact for OCT acquisitions, and clinicians actually inject right before the OCT pullback a bolus of saline, and that clears the blood so that there is no interference with the optical acquisition. So, you know, I should say we have seen some speckling, but based on kind of some of the image processing that we've developed to look at these data in vivo, the unique characteristics of these stent struts, we haven't had any issues yet. That being said, I have seen some OCT acquisitions where there's tremendous amount of speckling, and we absolutely could not apply this technique. So I think it, again, going back to one of the earlier questions, is making sure that we really have you know, very nice imaging data before we start this process. Your second question about multiple stents, that absolutely happens in the cath lab, particularly for individuals with diffuse disease. You know, we've talked about that. We haven't explored it, but the idea is for multiple stents, you actually have, they overlay each other. And so in that case, you would need to identify what stent strut corresponds to what stent. And I think that brings up kind of a new set of challenges that we've yet to explore, but it's definitely something of interest given the you know, the multiple stents that can be deployed in an individual patient. Yeah, great question.
Yeah, thank you, great talk.
Wow, this session, questions keep on coming. So continue. Sam, do you want to unmute yourself and ask the question, or should I read? Oh, so I'll read the question, which is, do you see any scope for using this technique for patient-specific design of the stents?
Yeah, Sam, great question. We kind of go back and forth between that, right? The idea of stent manufacturing, which didn't really go into, it's a fairly tedious process. Most of these stents are laser cut. We're talking about, you know, laser cut at diameters of about a millimeter. And the idea of customizing these manufacturing process, I think, is a little too much to think about currently. Whether we look at is kind of lesion specific stenting. And what I mean by that is we can really well characterize in vivo the type of lesion or plaque that a patient is going to get treated at, you know, whether it has a significant amount of calcium, so it's rather stiff, versus very lipid rich, fiber fatty rich, or very soft. And, you know, my thought is there are optimal stents for every lesion. And we're looking at really identifying what that optimal stent is. You know, we only looked at 2 stent designs here. There's hundreds of stent designs, and within each stent design, there's various geometries, diameters, lengths, etc. So we have a lot to work with. So I'm less interested in identifying a patient-specific stent, but more focused on kind of a lesion-specific stent.
Cool. Well, yeah, I think Manu, your class is over. We ran over time on your class.
My class is over, but that's not a problem. We can continue. I just don't want my students to feel like they have to stick around with us old folks here, you know?
I mean, this is great. So much discussion. So
yeah, that was an awesome talk, Luke.
Thanks, Emma. I appreciate that.